Welcome to the Grow Your Practice podcast. Hi, I'm your host, Chad Madden, owner of Madden Physical Therapy and Breakthrough. Join me each week as we dive into the best practices, systems, principles, tips, and tricks to help you grow your private practice.
Hey, everybody. This is Chad Madden with the Grow Your Practice podcast. And today, very excited to sit down with Mr. Steven Coen. Steven is the CEO and co-founder of SaRA Health, provider of RTM and patient communication. So welcome to the podcast here, Steven.
Chad, thank you very much for having me, and then for audience for listening. Hoping that we can give them a very valuable, section of their time today.
Awesome. Thanks. So RTM, hot topic. Something new. We have, just to set the context here, we have declining reimbursements that are going down dramatically. The cost of business providing care has gone up dramatically, especially in the last 3 years. Many owners today are scrambling for, how can we increase our revenue? RTM seems to be a very viable option. How did you get, if you can bring us up to speed, how did you start SaRA Health? What was the impetus to do that? And what was your career, leading up to that, preparing you for success here?
Yeah, Chad, I am a frustrated patient, which is why I started this company. But I didn't do it alone. Found my CTO, who was getting his master's in computer science at UCLA when I was getting my MBA, and then our head of clinical, Paul, who's a doctor of physical therapy, and spent about a decade at the Mayo Clinic in Rochester. So that's the Trinity, the holy Trinity of health tech, right? Clinical, business, and tech to start this. And we like to joke that we've been doing RTM since before it was cool, definitely before it was paid for broadly. So we started the company in 2018. We were helping these physical therapists primarily that were in value-based arrangements with high-risk employers like firefighters. So into the thousands of firefighters on the platform. And when we started experimenting with how to get them to engage, what we found is that, yes, some will do the log into an app or a web app. But what we found was if you could actually use a text message and especially use it in a way to provide some introspection, you could basically create this almost Pavlovian effect of, oh, this is how I feel. Now I'm going to go do my exercises. And the years of 2018 through 2022, we learned a lot, built an amazing product, an amazing team. And then when these codes came out, it was a gift. And I know I have advisors tell me you should say you had more forethought and all that. Like, no, we were just doing what we set out to do, which was improve the patient continuity between visits. And luckily, we were in the right place, right time for when policy caught up to where we've been heading for the 5 years prior.
Great. So you said something there that caught my attention, providing introspection. And then you also mentioned Pavlovian, which was super serendipitous that you brought that up, because I literally, that's the second reference in like the last 12 hours to Pavlov's dog. Yeah. So what did you mean by providing introspection there via text?
Yeah. So how SaRA works is a clinician will enroll a patient into SaRA. They give us a couple pieces of information. It takes typically about 30 seconds. And if they're on WebPT, Raintree, PT Everywhere, and a few others, it'll actually be integrated into their EMR, so they won't have to go to another screen. They enroll the patient, and from there, we're going to send a text message to each patient every day based on what they're being treated for, where they're at in their recovery plan, their type of treatment that clinician provides. So whether an exercise-focused, manual therapy-focused, where they're at, all sorts of these different data points. And the goal is to get them to answer one question. And so what we found in our previous years of experience was, if you can get them to answer that one question, we would watch as these firefighters would get the question, respond, and then go do their exercises. And so that was proof enough for our earlier customers that both in our previous business model, like, holy cow, this thing is working. And they had some really, really good outcomes in terms of injuries prevented and injury rates declining. So we had that. And then when these codes came out, just applying it to honestly what is a much easier patient population. Like, the injury prevention world was tough. You had people that weren't super motivated, which I guess maybe isn't too different than some portion of the bell curve of patients. And then you also had a scale, I guess, complexity, where it's typically one clinician to 400 patients or non-injured athletes. And so, yeah, that's how we learned about all this and we would literally see them answer and then go do their exercises.
Yeah. So super curious around the behavioral health, behavioral science aspect of that. I'm reading so Richard Hatton, 16 and a half psychological, I think it's called The Illusion of Choice. And it literally, he talks about one of the studies that I'm guessing led to that. What else did you try? I'm so curious now around that Pavlovian implementation there. What else did you try that ultimately led to, what other breadcrumbs did you try to get people to do a daily exercise? Because it's a challenge that we all have.
Leaderboards, gamification in the app, emails, even pushing stuff to the fire chiefs or other rungs of leadership. Broad communications. And what we found was, not only is it really the question, but it has to feel like it's coming from the clinician themselves. And so that was another big unlock. Is right now about 90% of our patients don't know that it's not their clinician texting them, and that's by design. And you can break that facade if you want to, but we highly suggest you don't. And we've measured that via survey, and then also we had an intern moment where, as we rolled out new languages, the intern set one of our super users as Spanish, and so all of his patients in rural Minnesota got all the messages in Spanish, and it was great. It was great, but the responses were amazing from a validation standpoint, because they were like, "Ha ha ha, Mike! I haven't taken Spanish since the third grade," or "Bueno?" Is that right? It's just people. It was like, holy cow, this is real. This is really working.
They didn't feel spammed.
No, they didn't feel spammed. No unsubscribes. 0 from that. So yeah, that's it's been fun.
Yeah, very cool. So I don't want you to reveal trade secrets or anything like that. Is there an example question or a template? Like something along the lines of, at least what we teach in marketing is, how are you? Some form of how are you is amazing at, reactivating patients in terms of conversation. Is there something like that you've learned that would be a valuable piece of information?
Yeah, my favorite question is our Goldilocks question. So how long are your exercises taking you? Which really is going to tell you 2 data points, assuming you get a response and they're not lying, which of course there's 2 assumptions you have to make, right? But if someone's going to respond, they're probably not going to lie, right? Especially with that. So it tells you, does this fit in their life? So I care about you, right? Like, does what I've given you actually fit into your life? And then also, are you doing it, right? Because you're probably not going to have opinion on it if you're not doing them at all. That's probably going to be one of your non-response days. So that's one of my favorite questions. And when it gets to more of that behavioral science and the clinical aspect, that's where I'd be like, hey, Paul, head of clinical, talk to him. He's the DPT that has all that expertise. We've gotten so deep, especially into the neuro population in particular, where we've seen a lot of success in stroke, Parkinson's, falls, vertigo, right? Because not everyone has a home exercise plan, nor is it a fit for them. And so how can you drive that therapeutic data coming back into this RTM platform, and for us at SaRA to be able to give the clinician that valuable data, to where we have anecdotally are hearing a lot of that, as a clinician, I'm not asking you, how was your pain, or were you able to get outside yesterday? I'm not asking those questions. I already have that data. And so when it comes to the appointment, I'm able to get out from my computer 3 to 5 minutes quicker, because my first question to you is, hey, Chad, I see that your pain has been going down and your exercises are getting a little too easy. Can we talk? Like, are you ready to progress to the next exercise? Like you've already checked so many boxes as a clinician, right? That you're able to at least get out in front of the screen quicker. Now, I'm not going to be disingenuous in saying I'm reducing documentation time yet for that. Uh, at the latter end, we are. I know we can get to that. But yeah, that's our goal is just to help clinicians be clinicians again, right? Like we have a couple of North Stars. One is to reduce clinician admin time to 5% and do everything we can to get there. And the other is to be able to make it make sense for practice owners, but be able to raise the average salary for PTs to $150,000. I mean, 112 grand coming out of student loans is insane and completely it's unsustainable. And so that's what we push the team on, and I push the team on, is how can we achieve these absolutely insane goals? Because if we do get close, then we're going to make for a better movement health population and clinician group.
I would love to ask you more questions about that, but we have a lot to hear. As an owner thinking about rolling out RTM, how do you go through, the first question we're going to ask is this worth it? So I know you have a very specific tool, which we can link to here in the show notes for everybody, but you have an ROI calculator. How do you help owners? How are you helping owners think through, should I be adding RTM to my practice?
One of the big things that we find we have to shift a lot is don't think about purely top line revenue, right? If you think of how an income statement looks, you have your top line, you have your cost of goods sold, then you get to your gross margin, and then you start to look at EBITDA and net income, right? I'm breezing through it, but thinking about that RTM code is really how much margin do you get to keep for that? And that's how we've always thought about pricing our product, is how can we give practice owners at least a 4 to 5x ROI on their money to us. So if, in our pricing model, just say it is $15 per billable patient per month for $98977. So first month Medicare, you're getting paid roughly $75, right? Is the national average. You're keeping 5, we get 1 for every month thereafter. If it's on the backs of our platform. So if we get the engagement, because that's our problem, that's our service, then you get paid and we keep basically a quarter for month 2 and thereon. So as you're looking at how much margin am I getting per visit, right? Maybe it's $20. And how much margin am I getting on the first month of RTM? If you include some staff time in there, which is iffy, like you're still probably at with us $50 for that first month of RTM and margin. So that's 2.5 visits in comparison. So a lot of times what we find ourselves doing is having the stop thinking about the revenue piece, because revenue can get eaten up with cost. Think about what kind of margin RTM drives, and that's the way that I find myself trying to shift thinking quite a bit with practice owners.
Great. So if you look at I'm going to ask you like the Ray Kroc milkshake, McDonald's brothers milkshake question, but if you look at your most successful practice owners who've rolled out RTM, and I know we've had Brad Saunders on the podcast, practice manager in the Carolinas. So those successful practice owners that are rolling it out, what are they doing that is different from the rest of us? How are they standing out?
They're doing what's best for their practice. And I'm not going to give you like it depends. I'm actually going to give you an answer. They're doing what's best for this practice. So I think of Mike at Kinetic. They're outside of Chicago, and very much a tight-knit, almost very much a family feel. When I went in there for the onboarding, like it feels like a family when you walk in there. And like, hey, we're going to do this because this is the best thing for our patients and our clinicians, and it's how we're going to be able to not only survive amidst these Medicare cuts, we're going to be able to thrive. And that was enough, right? And having that closeness of a group can allow you just to, hey, we're driving towards this better mission, and this is a tool to help us get there. For others, we've seen where it can be really helpful to incentivize the clinician. So we have some practices that are on, basically RVU type models where that's helpful. But I will say we've done some A/B testing with this, and in general, clinicians, when they hear about our outcome study, have a higher adoption jump than when they hear they're going to get a bonus. So in general, it's really about the outcome. So that was surprised to me. I mean, I'm a business guy. I figured, oh, like you incentivize with extra cash. I mean, I know what I would do, right? That was me all throughout high school, college. Like, oh, I can make more money by starting a business. Like, okay, yeah, I'll do that. Absolutely. Oh, I have to work more? Fantastic. This will be great. So the clinical side, now some are going to be, more, hey, and I think there does need to be a sharing of the wealth in general for this, but thinking a pure financial incentive is going to work, I think is a fool's mission. And there needs to be that clinical, either leading with the clinical or at least clinical sandwiched in with a financial incentive.
Feels like it would be amiss if I didn't ask what was in the outcome study.
So we did it with our practice in Rochester, Minnesota, Active PT, and basically what we did was did a randomized collection of patients that were not on RTM or SaRA and patients that were on SaRA, and then looked at their photo scores. And what we found was that patients got more better faster if they were on SaRA. So they were 2.3 fewer visits. They were, I think, either 11 or 12 more photo points. And again, my non-clinician is showing, but 11 or 12 more photo points than the control group. And and here's again where we get back to the margin discussion, is the total cost, and maybe we can talk about the payer side as well here. The total cost of care went down by about $120 to $130, but the margin per episode went up by 47. And so even if you just, ceteris paribus, hold it all even, you're making more per episode, even though your staff has fewer visits. Like, that's a good thing. Now, if you start layering on, oh, well, now I can get more evals in, the model gets even prettier, but just holding it all even and saying, okay, this is what RTM enables for us. That yes, maybe it is a couple fewer visits, and yes, maybe that does include some sort of top line depression, but my margin is better, which means my business is healthier.
Great. So the visits going down per plan of care can be a good thing both for the patient and also for the practice.
Yep.
Great. Sounds like a win-win. So tough question here. And I've asked this question for every RTM guest that we've had on here on the podcast. The one genuine concern that I had as an owner when I first heard about RTM, and just for some context, the first time I ever treated anybody online was 2011. So which was wild. Treating somebody over Skype is what we had at the time. Brutal. But so treated somebody virtually and then did that for a couple of years, but got away from that model. Now, because of what we've gone through in the pandemic the last 3 years, the hybrid model seems like it's very much here to stay. But the concern that I've had is here we're relying, if we look at what's happened over the last 30 years in the marketplace, insurances in general have not only not kept up with inflation, they're dramatically flat, right? 30 years, just completely flat. So declining reimbursements. And yet here again with RTM, it seems like we're relying again on insurance companies. So open floor, how do we think through that as an owner, that I'm not once again hopping in with solely with insurance companies and letting my marketplace value be dictated by them?
It's a tough question, and for us, I don't know if I have a good answer for your practice owners, but it's why we're already starting to do research ourselves so we can arm practice owners with that data. Like, hey, Blue Cross, you pay less when you use us, and we make better margins so we can see more of your people. If you have people going out of network like crazy that aren't taking you, that aren't taking United, that aren't taking whoever, because you have me on a $55 a day rate that I'm just not going to take anymore, right? And so there's a healthy tension, even if it doesn't feel like it. And I, in general, think that PT has been kicked a lot more as an industry than any others. And uh, I want the underdog to succeed. And so I don't know, that's one of our driving forces is like, gosh, like I can go into a PT and move better. I can send my grandma in to not have to worry about her falling either as much or at all for an extended period of time. I can have my dad go visit to be able to actually be able to get the pain out of his knee and be able to move better with my son, his grandson. What other practice provides that type of freedom, of movement freedom? And I know I'm preaching to the choir a little bit, but I I think that I think the reason that Medicare put this in the first place is their falls epidemic is not getting any better, and their social isolation is absolutely getting worse. And it's so much so that that's what the Surgeon General has gone on to talk about in a few of his last, public remarks. And I don't think it's too much to say preceding a fall is a decline in movement health. That's pretty easy, right? For the most part. Now, granted, of course, there's balance and all sorts of other things and medication adherence and all that. I think also a decline in movement health is the major lead to social isolation, right? If you can't get out into the world and you're making people come see you, it's going to be harder. Like, that it's logical, right? And so as I'm Medicare and I'm thinking, oh, these are my two biggest health risks, I got to figure out something to be able to juice the PT experience and the OT experience. And now, as you have all these other groups that are coming into Medicare Advantage and other managed care, and they're starting to see like, man, holy cow! My wife is a nurse practitioner. She works in an internal med group that goes into senior living, primarily assisted, and she sees it every day. We talk about it every night. Man, if these people could just move a little bit better,
Yeah.
and just as much as you don't want there to be pain, pain is what causes change. And I think you're starting to see this groundswell in especially that last pieces of life and people starting to realize like if we invest in movement health, it's going to pay off really, really well. That's why we put these codes in already. And I'm an eternal optimist, so hopefully I'm right. But yeah, I think that's why I wouldn't I wouldn't worry about it as much, at least in my opinion. I'm basing my entire business off it. I'm basing my entire business off one CPT code, right? Like one that we do really well. And so this isn't something I take lightly.
Fair enough. What I heard in there is doing the right thing and also make sure we collect a ton of data so we can justify what we're doing in the journey and the process.
Absolutely. So when these medical policy reviews come up every year, which they do for each and every payer, we can start to be able to push data to them and say, hey, here's the reason why you should cover it. And yes, of course, it has to include some sort of cost of care and outcomes and all of that with it. But it can also include extra margin for you at 100%.
Great. So we'll link out to the ROI model for everybody here. All right. The couple of questions for you. We can go two different ways. When's your next lifting competition?
I'm still deciding between the American Open 1 in Columbus, Ohio, or Masters Nationals. I believe that's in Reno. So one of the two. I'll go out and put a very mediocre total on, and that'll be that. If you want to see me in and of course it's branded because it'll always be branding. I do have a SaRA Health singlet that I wear. So
that's great.
Maybe I'll give you one of those pictures to link out to as well.
What is the best way for our listeners to learn more about SaRA Health and contact you, Steven?
Absolutely. SaRA Health, so SaRA Health.io is our website. Please come visit us there, and that's where we have an ROI calculator that you can use that assumes 0 timed codes. So we do not assume that you will put any time into this to be able to make this work for you and your own return on investment. If you decide to do that, we can show you what that means. But that's we build on the backs of our software, and that's our model, versus having to make time codes work to get the ROI that you need. And my email is Steven, so Steven at srahealth.com. Feel free to reach out directly. Pretty active on LinkedIn too, so don't hesitate to do that. And I'm generally posting one RTM rant a week. That is generally 2-3, maybe 2 minutes read, so pretty quick. So if you like rants and want to learn more about RTM, I try to make it as digestible as possible.
Cool. I know another question that I wanted to ask you. Update for insurance companies who are now reimbursing the CPT code you mentioned. Where are we at today with our team?
We've seen multiple Blue Cross Blue Shield plans pay. We've also seen a couple not. So in particular, Blue Cross Blue Shield of Illinois and Blue Cross Blue Shield of Kansas City, we have seen denials, and then provide communication that they're not covering these. Michigan, Blue Cross Blue Shield has been a little bit of a bear, but is covering it. So take wins with the losses. United has been really good across the U.S., which is a big surprise to most. I'll get to why that's not. Cigna came out and did their weird, we're not going to pay for it, now we might. And we've heard from some other customers that's been good. Aetna, Humana, Emblem, and a few other of the more Medicare, Medicaid specifics have been solid. It's definitely not completely unanimous, but it's looking better and better by the day. So I think you can check your physician fee schedule. Obviously, that doesn't always mean they're going to cover it. We have some folks that are really intensive about pre-auth, and that's a strategy as well to double check that for sure is going to get covered. So all in all, I'd say it's been good. It's been good with some unfortunate folks that have either pulled out or honestly their systems haven't caught up to it. It's also very possible that their systems simply haven't caught up to it. We had one group that got denied because they weren't of the correct provider status, despite them being a DPT. And I can almost guarantee you that once the appeal gets done, they're going to say, "Oh, sorry, we thought this was our PM that had to be an MD." Like we've seen nonsense. That was one of my last LinkedIn posts. Like with RTM, expect nonsense. And it's unfortunate, but those are some of the things we've seen and helped our practice owners be able to fight through, and now have a partnership with a rev cycle company that actually is the expert in remote patient monitoring, where if a clinic decides they want to do this, they basically can put in SaRA. We'll do all of the engagement. Of course, the clinician still has to intervene if there's anything that happens. We don't step into the patient-provider relationship. But at the end, basically, yep, sign off on this. Good. We bill it for you, and it's mailbox money. So we'll do the full cycle if folks want that. And part of that was driven by just the nonsense and us not accepting that this can't be easy.
Yeah. Sounds like overall it's moving in the right direction.
Moving in the right direction. And I think as more folks, and it's not just us that's doing research, there are other RTM companies and RPM companies that are doing really, really good research. And we're going to continue to publish and put data out there that shows that this really works. And that's how we're going to be able to fight this. And even if the payers broadly push back, well, then there are other opportunities with self-insured employer plans and other things to where there's this nice healthy tension to where you can start to be able to make things happen. That's 2, 3, 5 years down the road to be able to start making those plays, but that's how quick insurance works. So that's fine.
Great. 2 more questions. I think I said 2 more before. Now I really mean it. The growing up, the book that influenced you the most.
Ooh. I think I've read and reread the Lord of the Rings trilogy probably 7, 10 times. I did easily double digits. I'm a Christian, and try to do my best to follow my faith, though I fall astray from time to time. And I love how Tolkien was able to really create a wonderful story about being able to, and for some it signifies addiction and being able to beat addiction in that massive saga. And I think it's just really overcoming any adversity that the world throws at you. And I love the creativity, like all of it. And so that's been the most, I think, influential in terms of thinking creatively, being okay with the hard times and the adversity, knowing that almost inevitably there's something better at the other end.
Nice. Wow, we went Olympic lifting to Lord of the Rings. Very nice. And final question, what's your goal for whatever meet? What's your total goal?
Total goal. Honestly, I want to place top 10, and I'm guessing that's going to require somewhere around a 110 snatch, so 240, 245 pounds, and then probably a 137, 140 clean and jerk. So 315. That's my guess of what's going to take. And we'll see. We'll see. Training has to go well, but it's not crazy.
Awesome. Well, Steven, thank you so much for being on the podcast here. This was great. And for all of our listeners, again, we'll be linking out that ROI calculator, Steven's LinkedIn, and also the SaRA Health website here. Thanks again, Steven.
Thank you, Chad.
Remember to visit getbreakthrough.com to access our free resource library designed specifically for private practice growth. While you're there, make sure you register for a complimentary growth assessment to learn about potential opportunities for growth in your local market. Again, thank you for tuning into the Grow Your Practice podcast and supporting our mission to help people in pain get back to normal naturally.